Hello, I'm Dr. Edward Bote, the Medical Director of the Iowa Poison Control Center, which is located in Sioux City, Iowa. Today we'll be talking about toxidromes. This is my conflict of interest declaration. I have no conflicts of interest with regard to this presentation. However, there are off-label uses of medications that will be discussed during this presentation. There is a national phone number for poison control centers that works across the nation. It's 1-800-222-1222. It works just like 911, so no matter where you are in the country and places like Puerto Rico, the American Virgin Islands, and even American Samoa, if you dial 800-222-1222, you'll be routed to your local poison control center. These poison control centers are staffed 24 hours a day, 7 days a week, 365 days a year by nurses and pharmacists who are specially trained in medical toxicology. The nurses and pharmacists are backed up by physicians who are board certified in medical toxicology. So first, let's talk about what is a toxidrome. A toxidrome is a combination of symptoms and signs that are characteristic of exposures to certain classes of medications or substances. The name itself, toxidrome, comes from merging of the words toxic and syndrome. So it is a toxic syndrome that is characteristic for specific medications or specific chemicals. We'll be discussing toxidromes of different types throughout the rest of this talk. The toxidromes we will be discussing are in their classic forms. That means the prototypical toxidrome. If somebody has ingested multiple medications or has been exposed to multiple medications or chemicals, the toxidromes may not present as cleanly and as nicely as what will be described here. So it's important to be aware that a toxidrome may not be completely exactly as described here, depending upon what the circumstances are with the patient. The toxidromes we'll be talking about today are listed on this slide: anticholinergic, cholinergic, sympathomimetic, sedative hypnotic, opioid, tricyclic antidepressant, salicylates, methemoglobinemia, and serotonin syndrome. These are some other toxidromes that toxicologists keep in mind. However, we will not be discussing these during this talk. A quick mention about treatment principles for toxicology patients. First off, good supportive care is important for all toxicology patients. Most of the time, when people are exposed to chemicals or pharmaceuticals, there may not be a specific antidote for that chemical or pharmaceutical. Therefore, good supportive care is important for those people. Even in cases where there is a specific antidote for a chemical or a pharmaceutical, good supportive care is still important. Making sure that the patient has a patent airway, that they're breathing, they have adequate blood pressure and perfusion. That is all important with all patients, including toxicology patients. When it comes to a choice of a vasopressor, if somebody is hypotensive and they're not responding to fluids, typically we recommend using norepinephrine. As you see through the rest of this talk, we'll mention norepinephrine as a vasopressor of choice as opposed to something like dopamine or vasopressin. Antiarrhythmics, we typically recommend using lidocaine. There have not been a lot of studies that have actually looked at the use of amiodarone in poisoned patients. There have been a decent number of studies that have looked at the use of lidocaine, and therefore lidocaine is typically what we recommend for arrhythmias that are not responsive to other therapies. When it comes to seizures induced by toxins, pharmaceuticals, or chemicals, we recommend using benzodiazepines, and typically a lot of benzodiazepines, in order to stop or prevent seizures from happening. When people seize from being exposed to a chemical or a pharmaceutical, typically their brain in total is overactive. There's not a specific focus that is causing the patient to seize. It's an overall problem in the brain. Therefore, using lots of benzodiazepines helps calm the brain down and stop and control seizures. If a person is not responsive to benzodiazepines, typically after that we will recommend using a barbiturate and sometimes propofol. Propofol can't be used in large doses because of some of the cardiovascular side effects that are associated with it. Lastly, we make sure to look for non-toxicologic causes of the patient's problems. Sometimes we get told that a patient presents with certain symptoms and that they have been exposed to a certain chemical or pharmaceutical, and it turns out that it's something else, like a medical problem, that is actually causing the patient's condition. So it's important to remember, look for non-toxicologic causes also. This next slide briefly mentions several important points regarding 3 antidotes that are frequently used in toxicology patients. First, activated charcoal. While activated charcoal has been used for many decades in the treatment of poisoned patients, there have never been any studies that prove that activated charcoal improves the outcome of the poisoned patient. If activated charcoal is going to be administered to a poisoned patient, it is best to do it soon after the exposure, but only if it can be administered safely. If the patient cannot protect their airway, and intubation is no guarantee against aspiration, do not administer the activated charcoal. Given that there is no proven benefit in outcome, it is better to forego giving activated charcoal rather than get the charcoal into the patient's lungs. Next is flumazenil, the benzodiazepine antagonist. We generally do not recommend the use of flumazenil except in certain limited circumstances. Administering flumazenil to the overdosed patient can lower the seizure threshold and precipitate seizures in persons predisposed to seizures or who have taken a seizure-inducing medication or drug. Flumazenil may also precipitate benzodiazepine withdrawal seizures in patients chronically taking benzodiazepines. There are two significant cautions that must be remembered when administering naloxone to the toxicology patient. First, naloxone may cause opioid withdrawal in patients chronically taking an opioid. Vomiting and aspiration are a possible consequence of said opioid withdrawal. Second, and more importantly, the duration of effect of the naloxone is shorter than the duration of effect of most opioids, especially the sustained-release opioids or opioids with a long half-life, such as methadone. Once the naloxone effect wears off, the opioid effect may return, leading to resedation, decreased respiratory drive, and possibly apnea, or even death. We have taken care of multiple cases at the Iowa Poison Control Center which have had bad outcomes because of the naloxone effect wearing off before the opioid effect did. The first toxidrome we'll talk about is the anticholinergic toxidrome. This occurs because of a blockade of acetylcholine receptors in the nervous system. Specifically, it's a blockade of the muscarinic subtype of cholinergic receptors. There are two types of cholinergic receptors, the muscarinic and the nicotinic. And when we talk about the cholinergic toxidrome in the next toxidrome, we'll get into a little more about the different types of receptors. However, when it comes to the anticholinergic toxidrome, we're talking about blockade specifically of the muscarinic receptors. Causes of the anticholinergic toxidrome are varied. As you see on this slide, first generation or older antihistamines are very well known for causing the anticholinergic toxidrome, particularly diphenhydramine or dimenhydrinate, and you can also see the anticholinergic toxidrome caused by other older antihistamines such as brompheniramine or chlorpheniramine. Belladonna alkaloids such as atropine, scopolamine, and hyoscyamine will make somebody anticholinergic when they're exposed to too much. Some of these belladonna alkaloids are found in the belladonna plants, and they're also found in Jimson weed seeds. Older antipsychotics of the phenothiazine class, such as prochlorperazine and chlorpromazine, will cause the anticholinergic toxidrome. They're very similar in structure to the tricyclic antidepressants, which include amitriptyline and nortriptyline, and both the phenothiazines and the tricyclics will cause anticholinergic signs and symptoms. What are the signs and symptoms we're looking at or we'll see when somebody's anticholinergic? Well, first off, their pupils will be dilated. Pupils can be dilated for different reasons, and when we talk about the sympathomimetic toxidrome, we'll notice that the pupils are dilated there also. But pupils are dilated in the anticholinergic toxidrome. The blood pressure may be normal. Sometimes it's elevated. If the person's been exposed to a lot of the drug or chemical, it will be elevated. Their pulses increase. These patients are typically tachycardic. The respiratory rate is typically increased. It's occasionally decreased, but usually it's increased. Temperature is elevated. These patients will be hyperthermic. And their mental status will be anywhere from confusion and agitation all the way up to seizures and coma. They may also be hallucinating or delusional. That is one of the things that's frequently seen in patients who are anticholinergic. So large pupils, hypertensive, tachycardic, increased respiratory rate, and hyperthermia. Other signs and symptoms that will be noted in the anticholinergic toxidrome include dry mucous membranes. The skin will be warm and dry and red typically. These patients will be flushed, but they typically aren't going to be sweating. They also will have hypoactive bowel sounds and urinary retention. Some of these anticholinergic medications, particularly the older antihistamines, the tricyclic antidepressants, the phenothiazines, can cause widening of the QRS on EKG. These drugs will block sodium channels, and the sodium channels in the heart, by blocking them, will cause the QRS to widen out. That's one thing that we keep an eye on when patients have been exposed to these pharmaceuticals. This next slide is a little mnemonic that I'm sure a lot of people have heard when it comes to remembering the signs and symptoms of the anticholinergic toxidrome. You have red as a beet because their skin is red and flushed, blind as a bat because they have trouble seeing, dry as a bone, they're not sweating, mad as a hatter because they may be hallucinating or delusional, hot as a hair because their temperature is elevated, heart races on alone because they're tachycardic, and bowel and bladder lose their tone because they're constipated and have urinary retention. Treatments for the anticholinergic toxidrome first start off with good supportive care, as was mentioned previously. These patients may be significantly agitated or hallucinating, so large doses of benzodiazepines may be necessary to control their agitation. If they do have a wide QRS seen on EKG, we typically treat that with sodium bicarbonate. The sodium bicarbonate does two things. It is both a sodium load and it is a bicarbonate load. Changing the pH and bringing the pH up to a target of 7.50 to 7.55 and the sodium load both work together to help reverse the widening of the QRS that can occur from these anticholinergic drugs. There is a temptation to want to give a procholinergic drug to somebody who is anticholinergic. There are certain very limited circumstances in which the poison center or I will recommend using a procholinergic drug. So if you do have a question about using a procholinergic drug or want to use a procholinergic drug in an anticholinergic patient, please call the poison center first. There are certain uses of procholinergic drugs, particularly with the tricyclic antidepressants, the phenothiazines, and the older antihistamines, that the use of the drug can actually precipitate a very bad outcome for the patient. The next toxidrome we'll be talking about will be the cholinergic toxidrome, and this is the opposite of what we were just talking about with the anticholinergic toxidrome. This occurs when there is an excess stimulation of acetylcholine receptors in the nervous system. Both subtypes of cholinergic receptors, both the muscarinic and the nicotinic, are overly stimulated in this toxidrome. This becomes important a little later on when we talk about treatments for the cholinergic toxidrome. One treatment works specifically on the muscarinic signs and symptoms, the other works specifically on the nicotinic signs and symptoms. You may be familiar with the mnemonic dumbbells or sludgem. Those are the muscarinic signs and symptoms, and those are typically seen when there is a very large exposure to one of these chemicals or drugs that produces the cholinergic toxidrome. Very tiny exposures to procholinergic drugs, the patient may actually be more nicotinic than they will be muscarinic. And so while we look for the dumbbells or the sludgem mnemonic, that may not be seen in very tiny exposures to these chemicals. So what happens? Acetylcholine accumulates typically because of a blockade of the enzyme acetylcholinesterase that breaks down the acetylcholine in the nervous system. So by blocking the enzyme that breaks down the acetylcholine, it builds up and it winds up causing the cholinergic toxidrome. What will inhibit the acetylcholinesterase? Well, as you can see on this slide, there are three main categories that we look at. You have organophosphate insecticides, some of which are malathion and diazinon. The military nerve agents that are used are a subgroup of the organophosphates. Carbamate insecticides are another group of chemicals that will induce the cholinergic toxidrome, and some of those that are commonly used are 7 and aldecarb. There are also some procholinergic drugs that we use therapeutically for people. Those anticholinesterase medications include physostigmine, pyridostigmine, and neostigmine. A quick talk about normal nerve function, and then we'll show how the cholinergic toxidrome affects the nervous system. This first slide shows that a signal has come down a nerve and releases acetylcholine into the space between the nerve and either another nerve or target organ. The acetylcholine moves across the space to either the next nerve or the target organ and either produces another nerve signal or causes the organ, particularly a gland, to secrete fluid. The acetylcholinesterase, the enzyme that breaks down acetylcholine, very quickly breaks down the acetylcholine and the signaling stops. So one way to look at this nerve transmission, is quickly turning a light switch on and off. So turning the light switch on is the release of acetylcholine. Turning it off is the action of the acetylcholinesterase breaking down the acetylcholine and stopping the signaling. However, when a person is exposed to one of these cholinesterase blocking drugs, such as the physostigmine or one of the organophosphate or carbamate insecticides, the signaling doesn't stop. As you can see on this slide, you have multiple signals happening in the downstream neuron or the downstream gland, and signaling is persistent and repeated because the acetylcholine keeps triggering the signal. Using the light switch analogy, instead of the light switch going on and off, the light switch goes on and continuously stays on because there's nothing to turn the light switch off. The cholinesterase enzyme isn't available to break down the acetylcholine, and therefore signaling continues repeatedly. The signs and symptoms that we get from this continuous signaling, the cholinergic toxidrome, the first set of symptoms that we have are the muscarinic signs and symptoms. That is the mnemonic dumbbells that you see on this slide. I like using the mnemonic dumbbells as opposed to sludgeum because dumbbells has the B in it. The B stands for bradycardia and bronchorrhea. Typically, when patients die from the muscarinic signs and symptoms of a cholinergic esterase inhibitor exposure, they die because they flood their lungs with fluid. That's what bronchorrhea is, flooding the lungs with fluid. Pulmonary edema would be another way to think of it. People can't breathe when their lungs are filled with fluid, and that's what leads to their demise from the muscarinic side of cholinergic toxidrome. Other signs and symptoms that you get on the muscarinic side include diarrhea, diaphoresis, urination, meiosis, or small pupils, emesis, vomiting, lacrimation, and salivation. As already said, the most important sign and symptom that we worry about with the muscarinics are the bronchorrhea. We have an antidote specifically for the muscarinic signs and symptoms, and that is titrated to the bronchorrhea. For the nicotinic signs and symptoms, we use the mnemonic of the days of the week. The most important symptom under the nicotinic side is muscle weakness, which will eventually lead to muscle paralysis. The muscle paralysis is important because that means the respiratory muscles are paralyzed and the person cannot breathe. Combining inability to breathe plus the bronchorrhea, the pulmonary edema, the flooding of the lungs with fluid, leads to a patient's demise. Also, in large exposures to these chemicals or these pharmaceuticals, the patient will have seizures, and those seizures can also lead to a patient's demise. The other signs and symptoms that we have are mydriasis, or dilated pupils, which you'll notice is the opposite of the meiosis, which was mentioned on the previous slide. Tachycardia, which is the opposite of the bradycardia seen on the previous slide. The weakness leading to muscle paralysis, hypertension, muscle fasciculations, and seizures. So as mentioned a little earlier, very tiny exposures to these chemicals will make the person more nicotinic than muscarinic. So with very tiny exposures, they may be tachycardic, hypertensive, and have dilated pupils. Whereas when the exposure gets larger, they then become bradycardic, hypotensive, and have meiosis or small pupils. When it comes to treating the cholinergic toxidrome, we have three classes of pharmaceuticals that we use to treat the signs and symptoms. The first class is atropine. It treats only the muscarinic signs and symptoms and does not affect the nicotinic signs and symptoms. It dries secretions very well and relaxes smooth muscles. The smooth muscles in the airways will constrict during a cholinergic crisis, and therefore the atropine helps dry the secretions in the airways and also relax those smooth muscles in the airways. Atropine can be given by any of the four routes that are listed on this slide: intravenously, intramuscularly, intraosseous, or through an endotracheal tube. The most effective way to give the atropine is via intravenous route. If that is not available, intramuscular or intraosseous are also reasonable alternatives, and typically endotracheal tube administration isn't as effective because you have a lot of secretions coming up the tube and it's hard to get the atropine down the endotracheal tube. The atropine will help dry secretions, but it will not have any effect on the pupils or on the fasciculations in the skeletal muscles. It's important to remember that when a patient is hypoxic, if you give them atropine when they're hypoxic in a cholinergic toxidrome, it may precipitate ventricular arrhythmias. How much atropine is given? Well, the simple answer is until all their secretions have dried up and it's easy to ventilate them. So there isn't an upper limit of the amount of atropine that a patient may need in order to treat their cholinergic toxidrome. As you see on the slide, it says do not rely on heart rate, pupil size, or other findings. The atropine is titrated to the amount of bronchial secretions that the patient is having. When it comes to exposure to military nerve agents, 20 to 30 milligrams is typically what's believed to be the upper limit of atropine that will be needed to treat those patients. However, patients who are exposed to organophosphate or carbamate insecticides that are used commercially have had the tendency to, in some cases, need very large doses of atropine. As you can see, it says 2 to 3 grams may be necessary. When I was taking care of a patient during my toxicology fellowship, the patient had been exposed to an organophosphate and was exposed extensively over their body and needed about 1.4 grams of atropine in the first 24 hours after the exposure. The second group of pharmaceuticals that we use to treat the cholinergic toxidrome is pralidoxime, sometimes referred to as 2-PAM. This helps treat the nicotinic symptoms, and it also helps remove the chemical or the drug from the enzyme. So it helps regenerate the enzyme, so the enzyme starts working again, and it also helps treat the nicotinic symptoms. As mentioned a few slides ago, the nicotinic syndrome that we look at the most is fasciculations leading to muscle weakness. That is what we titrate the pralidoxime to. We titrate it to muscle strength or muscle weakness. It does not have an effect on the muscarinic signs and symptoms, only on the nicotinic signs and symptoms. It can be given via IV or via autoinjectors through an IM intramuscular route. As said, it's titrated to the nicotinic symptoms, particularly muscle weakness. In patients who have been exposed to commercial insecticides where they've been cholinergic, we will look at whether or not they can lift their head up off the bed to test how weak or strong their muscles are. A patient who is not able to lift their head up off the bed typically does not have enough muscle strength, and we will continue treatment with the pralidoxime. The third class of pharmaceuticals that we use to treat the cholinergic toxidrome are benzodiazepines. Diazepam has been the most studied when it comes to use for military nerve agents or insecticides, but any benzodiazepine can be used to treat the patient's symptoms. The indications for using benzodiazepine are if the patient is seizing, or if they're agitated, or if they have a severe poisoning. Give the benzodiazepine to any seriously intoxicated patient, whether or not they're having seizures, because it helps calm the brain and it helps with long-term prognosis. The amount of benzodiazepine necessary is variable, typically starting off with the equivalent to 5 to 10 milligrams of IV diazepam and going up as needed to control seizures and agitation. The next slide shows 2 sets of autoinjectors that are used to treat the cholinergic toxidrome. The kit on the top of the slide, the Mark I kit, has been used for the military for many years. However, the manufacture of this kit was stopped in the early 2010s. It is, however, still in the Strategic National Stockpiles ChemPack program. Therefore, if there were an event where there are a great many people exposed to one of these chemicals, the ChemPack may be used to treat these patients, and the Mark I kit may be used in that scenario. The top autoinjector seen in the Mark I kit is the pralidoxime. You will notice it has a number 2 after it. The bottom injector is atropine, which has a number 1 after it. The idea is, with number 1, you give the atropine first, and then you give the pralidoxime second. The bottom kit is known as the duodot injector. That autoinjector is the same size as the pralidoxime autoinjector in the top picture. However, it contains both the atropine and the pralidoxime in the one autoinjector. It's made in such a way that it delivers the atropine first and then the pralidoxime second. So the patient will get both drugs through the use of only one autoinjector, as opposed to needing 2 autoinjectors, as is necessary with the Mark I kit. Toxidrome Case 1. In this case, a husband and wife were found unresponsive in a parked car. Both of them had constricted pupils or pinpoint pupils. blood pressure 124/68, pulse is slow at 61, respiratory rate is markedly decreased at 6 respirations per minute, and the temperature is 36.8 degrees. The mental status for both was somnolent and very difficult to arouse. Their pulse ox was in the mid 80%, but they did respond to supplemental oxygen, and the skin was warm and dry. The combination of unresponsiveness, small or pinpoint pupils, and decreased respiratory rate or apnea are the classic triad of the opioid toxidrome. The next toxidrome we'll talk about is the opioid toxidrome. In this, opioid medications and drugs stimulate the opioid receptors, producing a classic triad of symptoms. That triad of symptoms is CNS depression or coma, respiratory depression, and miosis, small pupils. There are many prescription opioids that can produce the opioid toxidrome when taken in large amounts. U-47700 is an opioid that has not been FDA approved, but is being used illicitly over the past few years. It is important to know that because testing for U-47700 has to be done at specialized labs. In the left-hand column of the slide, fentanyl is listed. On the next slide, we have a list of various fentanyl derivatives. In the upper left, there is a listing of 4 FDA-approved fentanyl derivatives. You have alfentanil, remifentanil, and sufentanil. All 3 of those are FDA-approved for use in humans. The carfentanil is used in large animals as an anesthetic and a tranquilizer. It is not approved for use in humans. There are many delivery forms of fentanyl, and that is listed in the lower left-hand side. There is IM, IV available, sublingual spray and tablets, a lozenge or a lollipop, buccal film and buccal tablets, so those are films or tablets that are put on the inside of the cheek, and there's also a nasal spray. In the recent past, there have been a lot of stories in the news about fentanyl derivatives being used illicitly. Fentanyl derivatives that have been used illicitly are listed on the right-hand side of the slide. None of these have been FDA approved for use in humans, however, they are being used illicitly and are being mixed with street drugs, and in some cases sold as heroin, leading to deaths because these fentanyl derivatives are much more potent than morphine and heroin. The classic signs and symptoms of the opioid intoxication or the opioid toxidrome are CNS depression or coma, respiratory depression, and miosis. Other effects that can happen include mydriasis or large pupils, specifically from meperidine or propoxyphene, and seizures are known to occur from dextromethorphan, which is structurally similar to the opioids, meperidine, propoxyphene, and tramadol. When it comes to pupil size in the opioid toxidrome, their pupils are small and sometimes pinpoint. Blood pressure and pulse are typically decreased, the entire body has slowed down, and respiratory rate can be decreased. Opioids are known to cause apnea, stop the patient's breathing. That is why there have been a lot of deaths associated with these very potent opioids. The patient stops breathing and they die. Temperature is typically normal or it can be decreased, and the mental status is typically depressed. Early on, the patient may have euphoria, the high that they get from using these opioids, but then the mental status progresses to confusion, stupor, and eventually coma. And as mentioned just a moment ago, the coma can be accompanied by apnea, which can lead to the patient's death. Treatment for the opioid toxidrome, first and foremost, is protecting the airway and maintaining ventilation. As already mentioned, it's typically apnea, stopping breathing, that kills these patients. If the patient is having a seizure, we again recommend benzodiazepines, and we also watch for aspiration and pulmonary edema. As they are unconscious, they may not be able to protect their airway if they regurgitate. The specific antidote for the opioid toxidrome is naloxone. It is very effective at reversing the respiratory depression, and it can also wake the patient up, reverse the CNS depression and coma. However, the use of naloxone should be titrated to the patient's respiratory rate and respiratory effort, not necessarily their level of consciousness. Naloxone needs to be used cautiously in patients who are opioid habituated because it may put them into opioid withdrawal. Use of naloxone has occasionally led to pulmonary edema, so after naloxone has been administered, that's something that needs to be watched for. And a very important point with the use of naloxone is that it typically has a much shorter duration of effect than many opioids. When using a long-acting opioid such as buprenorphine or methadone, or the sustained-release opioids such as the sustained-release oxycodone, the duration of effects of those opioids will outlast the duration of effect of the naloxone. Therefore, the naloxone can wear off, the patient can become resedated, and stop breathing again. There have been numerous cases in which that has happened, where the patient has gotten better after receiving the naloxone, and then hours, half an hour, or several hours later, the patient becomes resedated and becomes apneic again. So therefore, it's important to watch for that. If the patient has taken a long-acting opioid or a sustained-release opioid and is needing frequent doses of naloxone, a naloxone infusion can be used. That is not FDA approved, it is off-label, but it can be used in order to keep the patient breathing and or awake. The use of a naloxone infusion is not a substitute for keeping an eye on the patient to make sure that they have adequate respiratory rate and respiratory effort. Because of the large problem of opioid overdoses that have been increasing in the United States over the past few years, there has been a move to use naloxone outside the healthcare setting. In April of 2014, the FDA approved a naloxone autoinjector. That is what you see on the left-hand side of the slide. The naloxone autoinjector is designed in such a way that when the package is opened, there is a speaker that will give instructions to the person to follow in order to administer the naloxone autoinjector. In November of 2015, the FDA approved nasal sprays of naloxone to be used in opiate overdoses. The nasal spray that is seen on the right-hand side of the slide was FDA approved in November of 2015. If any of these forms of naloxone have been administered to a person, they need to get medical treatment. This is not a substitute for them seeking medical care. These forms of administering naloxone are a way of temporizing the patient until they can get to a healthcare facility and receive appropriate treatment. The next toxidrome we'll talk about is the sedative hypnotic toxidrome. The sedative hypnotic toxidrome occurs when patients or people have been exposed to drugs or chemicals which decrease the person's level of consciousness. What can cause the sedative hypnotic toxidrome? This slide gives a list, not an inclusive list, of drugs and chemicals and pharmaceuticals that can decrease a person's mental status. The one that is most familiar to all of us is in the left-hand column, and that is ethanol. All of these drugs, particularly ethanol, can decrease a patient's level of consciousness and lead to problems. What signs and symptoms will we see with the sedative hypnotic toxidrome? Typically, the pupils are mid-range, but they can be dilated or they can be constricted. Blood pressure, pulse, and respiratory rate are typically decreased because the entire body has slowed down. Temperature may be normal, but if the patient has been unconscious for a while, it may be decreased. Also, if they are unconscious outdoors during cold weather, they may suffer hypothermia from that also. Mental status typically starts off with confusion or agitation, but will eventually lead to stupor and coma. Other signs and symptoms that may be seen include nystagmus, decreased bowel sounds, dry skin, slurred speech, and ataxia. Specifically with the barbiturates, you can also see apnea, cardiovascular collapse, and death. The barbiturates are different than many of these other sedative hypnotics because they can stop a person's breathing and lead to cardiovascular collapse and their death. Some of the other sedative hypnotics that were listed on the previous page can cause significant decrease in mental status and decrease in respiratory rate, but typically don't cause apnea or cardiovascular collapse or lead to death. In cases where those other sedative hypnotics have been mixed with other sedative hypnotics or other pharmaceuticals, that may lead to apnea, cardiovascular collapse, and death in those circumstances. Typically, a single ingestion of the other sedative hypnotics will not cause these severe symptoms. Treatment for the sedative hypnotic toxidrome is mainly good supportive care. Make sure that their airway is patent and that they are breathing. Treat any hypotension. Treat hypothermia. Because these patients have the tendency to be down for a while and uncertain of how long they may have been down, check a CPK to see whether or not there's been any muscle breakdown. You also want to assess renal function and myoglobinuria, because if they've been down for a while, they may be dehydrated and not perfusing their kidneys well. And if there's muscle breakdown, that can lead to the myoglobinuria, which can also damage the kidneys. Phenobarbital specifically can be dialyzed. Ethanol can also be dialyzed, but the rest of these sedative hypnotics, for the most part, are non-dialyzable. Just phenobarbital and ethanol. Toxidrome Case 2. A 24-year-old is brought into the emergency department by EMS and law enforcement. The pupils are dilated, the blood pressure is elevated at 156/76, pulse is elevated at 137, respiratory rate is also elevated at 24, and the temperature is slightly elevated at 37.9 degrees. The mental status of the patient is agitated, combative, pulling against restraints, and not responsive to redirection. Pulse oximeter reads 97%, and the patient's skin is pale and diaphoretic. The combination of agitation, dilated pupils, tachycardia, tachypnea, hypertension, and a slight fever would make you think of the anticholinergic toxidrome. However, the diaphoresis does not fit with the anticholinergic toxidrome. In that toxidrome, their skin is warm and dry, so this constellation of symptoms actually fits with the sympathomimetic toxidrome. The next toxidrome we'll talk about is the sympathomimetic toxidrome, also referred to as the adrenergic toxidrome. This is seen when there's excessive adrenergic stimulation. What can cause this excessive adrenergic stimulation or the sympathomimetic toxidrome? This slide has a list of some pharmaceuticals and chemicals that can do that. We are all familiar with amphetamines and methamphetamines causing people to be sympathomimetic, but you also have things like caffeine, cocaine, the over-the-counter medications of ephedrine and pseudoephedrine, the illicit drug MDMA, also known as ecstasy, the prescription drug methylphenidate, and theophylline can also cause a sympathomimetic toxidrome. Some other illicit drugs that may do it include things such as PCP, the synthetic cannabinoids, which is typically referred to as spice or K2, or the synthetic cathinones that are typically referred to as bath salts. The signs and symptoms that we get from the sympathomimetic toxidrome are listed on this slide. Pupils are typically dilated, the same way as they are with the anticholinergic toxidrome. Blood pressure, pulse rate, and respiratory rate are typically increased also, similar to the anticholinergic toxidrome. The pupils may be small or constricted or normal-sized with PCP intoxications. However, the rest of the signs and symptoms just mentioned typically will be increased with PCP exposures. The temperature is also increased. Some of it is because of changes in the body's metabolism and also from the hyperactivity that these patients can demonstrate. Their mental status will typically be agitated and or restless, but it can also go all the way up to being confused, hallucinating, psychosis, and in severe cases can also cause seizures. Other signs and symptoms that can be seen in the sympathomimetic toxidrome include tremors, diaphoresis, arrhythmias, and increased bowel sounds. The sympathomimetic toxidrome looks a great deal like the anticholinergic toxidrome. The two main differences are the skin and the bowels. In the anticholinergic, we are talking about the skin being red and dry. In the sympathomimetic, the skin is typically wet, diaphoretic. In the anticholinergic, they typically have decreased bowel sounds, whereas in the sympathomimetic, the bowel sounds are typically increased. Treatment for the sympathomimetic toxidrome starts off with good supportive care. If they are hyperthermic or dehydrated, they need rapid cooling and IV fluids. Liberal use of benzodiazepines to treat agitation, tachycardia, hypertension, and hyperthermia is very important. As mentioned, you may need large doses of benzodiazepines in significantly intoxicated patients. If their hypertension does not respond to large doses of benzodiazepines, the use of a direct-acting vasodilator such as nitroprusside may be necessary to help bring down their blood pressure. The next toxidrome we'll talk about is serotonin syndrome. Serotonin syndrome occurs through the use, overuse, or combination of serotonergic agents that leads to an excess of serotonin in the nervous system, which produces 4 classical findings. The first is fever, the second is autonomic instability, the third is neuromuscular abnormalities, and the fourth are mental status changes. What will cause serotonin syndrome are listed on this and the next slide. The selective serotonin reuptake inhibitors, the SSRIs, are listed there, and you can see they include things such as citalopram, paroxetine, and sertraline. The MAO inhibitors, which the pharmaceutical ones include isocarboxazide, phenelzine, and tranylcypromine. Other drugs such as linezolid, methylene blue, and selegiline also have MAO inhibition activity. The tricyclic antidepressants such as amitriptyline, nortriptyline, and imipramine can also cause serotonin syndrome. This slide gives a longer list of other pharmaceuticals that can cause serotonin syndrome, including things such as mirtazapine, trazodone, lithium, and bupropion, the analgesics, codeine, tramadol, and meperidine, and there are illicit and over-the-counter drugs that can also be serotonergic, such as amphetamines, mescaline, ecstasy, dextromethorphan, St. John's wort, and tryptophan. Serotonin syndrome can happen when a person gets exposed to either too much of one of these drugs or when multiple of these drugs are put together. A not uncommon scenario is when somebody is on an SSRI or a tricyclic antidepressant therapeutically and then develop a cold or a cough, and they take over-the-counter medications that include dextromethorphan. The mixing of the SSRI and the tricyclic plus the dextromethorphan can lead to serotonin syndrome. Signs and symptoms from serotonin syndrome include dilated pupils, increased blood pressure, pulse rate, and respiratory rate. Their temperatures will be elevated, and their mental status will be anywhere from confused all the way up to coma and seizures. As mentioned, that there are 4 main groupings of signs and symptoms that are seen classically with serotonin syndrome. The first one is fever. The second is autonomic instability. That includes tachycardia, hypertension, and diaphoresis. The neuromuscular abnormalities are typically seen more so in the lower extremities than the upper extremities, and they can include tremor, hyperreflexia, and clonus. These patients have the tendency to be moving around, to be bouncing around in the bed. They are not calm. The muscular activity has the tendency to keep them moving. Lastly are the mental status changes. That can, as already mentioned, be anywhere from agitation all the way up to stupor and coma. Treatment for serotonin syndrome is to first stop the serotonergic agents that the patients have been exposed to. In some situations, such as the overdose situation, stopping the drug may not be possible. But if this is an interaction between therapeutically used pharmaceuticals, stopping the drugs is important. After that, it's good supportive care. If they are hot, make sure to cool them rapidly. And if they're dehydrated, provide them with IV fluids. Again, the liberal use of benzodiazepines is called for to treat the agitation and tremor. And if the large doses of benzodiazepines are not controlling all of their signs and symptoms, consider the use of a serotonin antagonist. Call the Poison Center and we'll be happy to provide advice on when and how much of a serotonin antagonist to use. The next toxidrome we'll go into are the tricyclic antidepressants. Exposure to an excess of these tricyclic antidepressants can produce a triad of symptoms. In this case, it's EKG changes, the anticholinergic toxidrome, and seizures. Causes of the tricyclic toxidrome are listed on this slide. You'll notice that amitriptyline and imipramine are metabolized to other tricyclics that are used primarily in the treatment of depression also. The signs and symptoms that will be seen in the tricyclic toxidrome include dilated pupils, blood pressure that may be either increased or decreased depending upon the severity of the ingestion. Very severe ingestions, it may be decreased. Pulse is typically increased, respiratory rate may be normal or decreased, and the temperature is typically increased. Some of the signs and symptoms we just mentioned are consistent with the anticholinergic toxidrome: the dilated pupils, the elevated heart rate and blood pressure, and the elevated temperature. Mental status can be anywhere from agitation and lethargy all the way up to seizures and coma. As mentioned in the anticholinergic toxidrome, there may be hallucinations. The Mad as a Hatter can also be caused by the tricyclics. Other signs and symptoms: the cardiac effects can include widening of the QRS. As talked about under the anticholinergic toxidrome, some of the anticholinergic drugs can cause sodium channel blockade and widening of the QRS. The tricyclics as a class will block sodium channels and will widen the QRS. Therefore, it's important to make sure that the EKG is followed. QT prolongation can also occur because of tricyclic exposures. There may be hypotension related to the tricyclic overdose from sodium channel blockade in the heart and also from vasodilatation. Large doses of tricyclics can act as a vasodilator. The CNS effects, as already mentioned, can be anywhere from agitation to hallucinations and seizures. Patients who seize from overdose of tricyclics have the tendency to seize early after an overdose, and the seizures are usually brief. Already mentioned, the anticholinergic toxidrome, as spoken about earlier, can be part of what is seen in the TCA toxidrome. Treatment for the tricyclic toxidrome first starts off with good supportive care, large doses of benzodiazepine for agitation and/or seizures. As mentioned previously, barbiturates are second line if they're not responding to large doses of benzodiazepines. If they do have widening of the QRS from sodium channel blockade from exposure to the tricyclics, we recommend using sodium bicarb. Just as was talked about under the anticholinergic toxidrome, we give the sodium bicarb to help narrow the QRS and have a target serum pH of 7.50 to 7.55. If they are hypotensive and not responding to fluids, norepinephrine is our next drug of choice, lidocaine for arrhythmias. And as mentioned during the anticholinergic toxidrome, you do not want to reverse the anticholinergic signs and symptoms that can occur in a tricyclic overdose because it can lead to very bad outcomes. Toxidrome case 3. A 19-year-old is brought into the emergency department after being found unresponsive in a dorm room with a suicide note. The pupils are mid-range, the blood pressure is 120/68, the pulse is elevated at 141, respiratory rate is notably elevated at 36, and the temperature is elevated at 38.3 degrees. The mental status, the patient is comatose, and if stimulated will become agitated but not interactive. Pulse oximeter is 93%, and a blood gas shows a pH of 7.18, a pCO2 of 24, a PO2 of 100, but a bicarb of 8.7. The constellation of tachycardia, tachypnea, fever, being comatose and agitated, and the significant metabolic acidosis leads us to the list of toxins that can cause metabolic acidosis with mental status changes. In this case, the cause of the severe metabolic acidosis is an aspirin overdose. The next toxidrome we'll discuss will be the salicylate toxidrome. Exposure to excessive amounts of salicylates, either acutely or chronically, can affect the brain. The brain is the target of salicylate toxicity. Whereas we normally think about acid-base abnormalities, those do contribute to the toxidrome, but it is the brain that has the significant effect that we worry about. Other things that salicylates can do is they stimulate the respiratory center in the brainstem, so the patient will breathe more quickly. Uncouple oxidative phosphorylation, that's the process by which cells make ATP, energy, and when that is uncoupled, it generates heat instead of energy. It is like putting gasoline in an engine of a car that makes work, or tossing the gasoline on the ground and setting it on fire. By tossing it on the ground and setting it on fire, you generate heat and not the work that you want. Uncoupling of oxidative phosphorylation generates heat instead of energy for the cells, and that can be a bad sign. Mortality correlates with the amount of salicylates that's in the brain, not the salicylate level that we draw in the blood. Therefore, watching the brain and the patient's mental status and signs and symptoms is very important. Acidosis causes more salicylate to get into the CNS, and patients who die have the tendency to die very quickly and very abruptly. Therefore, it's important to monitor the patient and be monitoring their acid-base status. What will cause the salicylate toxidrome is listed on this slide. Aspirin, acetylsalicylic acid, methyl salicylate, octyl salicylate, and magnesium salicylate are just a few of the common salicylates that are available. There are dozens of salicylates that are used therapeutically in different forms. Methyl salicylate can be found in liniments, rubbing balms that are used for sore muscles, and those are typically 30% methyl salicylate. However, oil of wintergreen can be 100% methyl salicylate. A 1-ounce bottle of oil of wintergreen with 100% methyl salicylate is potentially lethal to a teenager or even an adult. Octyl salicylate is found in sunscreen, and magnesium salicylate is found in back pain analgesics. The signs and symptoms from salicylate toxidrome: pupils are typically no change. Blood pressure is decreased in severe overdoses because of the patient's significant acidosis and poor cardiac contractility. Pulse and respiratory rate will be increased, as will the temperature. As mentioned a few slides ago, hyperthermia from salicylate toxicity can be a bad sign. Mental status can be anywhere from slight confusion all the way up to delirium, seizures, and coma. As mentioned, mental status is important to follow because it's the brain that is the target of salicylate toxicity. In the acute intoxication, the patients typically have nausea, vomiting, high respiratory rate, and they may have ringing in the ears or muffled hearing. Patients with ringing in the ears and muffled hearing let us know that is a beginning sign of CNS toxicity. They typically have metabolic acidosis. They may have hypoglycemia also. Cerebral edema and pulmonary edema can also occur in significant acute salicylate intoxication. Chronic salicylate intoxication usually isn't as dramatic as the acute intoxication. They typically don't have the nausea or the vomiting, but their brain is typically affected. They usually have nonspecific symptoms, and it's usually slow progression of mental status changes. Cerebral edema and pulmonary edema are more common in the chronic intoxication. Treatment for salicylate toxicity, or the salicylate toxidrome, includes getting a salicylate level now and following it every 2 hours. Salicylate will be absorbed over time from the GI tract. Salicylates can clump together, or they may be enteric-coated, and therefore absorption may occur for a while. As mentioned, it may take over 12 hours and in some cases over 24 hours to reach a peak salicylate level. Levels may also fluctuate as absorption from the GI tract varies over time. Treat the patient based on what their symptoms are, particularly what is their mental status, whether or not they're having tinnitus, the lab results looking at acidosis, and their salicylate levels. Glucose supplementation is important because, as mentioned previously, glucose may be low. Mainstay of treatment for significant salicylate toxicity is urinary and serum alkalinization and dialysis. Serum alkalinization is important because, as already mentioned, the more acidotic the person is, the more salicylate will get into the brain. Alkalinizing the serum and the urine will help increase the urinary elimination of the salicylate and prevent the movement of the salicylate into the brain. Anybody who has tinnitus, mental status changes, a severe intoxication, a salicylate level greater than 50 milligrams per deciliter, or the need for dialysis needs to have alkalinization occur. The goal of alkalinization is a serum pH of 7.50 to 7.55 and a urine pH of 8.0. The serum pH is what we worry about more so than the urine pH because we want to make sure that the person does not have acidosis, which, as already mentioned, will lead to more salicylate getting into the brain. Maintain respiratory alkalosis. In patients with a severe intoxication, they will be breathing very fast and very deep. We recommend not intubating the patient unless they truly are going into respiratory failure. The reason for that is because once a patient is intubated, there is the tendency to set the ventilator at standard ventilator settings of a normal respiratory rate and a normal tidal volume. That is not adequate for these patients who are breathing very fast and very deep with large tidal volumes. By setting the ventilator below where the patient was breathing, the patients will develop respiratory acidosis, systemic acidosis, more salicylate will get into the brain, and the patient can have a quick demise. Just about every toxicologist has a story of a patient who had salicylate toxicity. They wind up getting intubated, and within 20 minutes they have seized and died. For severe cases, hemodialysis will remove the salicylate from the bloodstream and will also help correct the acid-base abnormalities. The last toxidrome we'll talk about will be methemoglobinemia. Methemoglobinemia is a condition in which the iron in our red blood cells is oxidized from the 2+ oxidation state to the 3+ oxidation state. The hemoglobin in our blood carries oxygen by hooking it up to the iron in the hemoglobin molecule. Normally, that iron is in the 2+ oxidation state. There are times when the oxygen will take an electron off with it when it goes into the cells and will oxidize the hemoglobin iron from 2+ to 3+. We have enzymes in our body that help convert the iron in the 3+, the methemoglobin, back to the 2+ state, the normal hemoglobin. When people are exposed to large quantities of oxidizing chemicals or pharmaceuticals, they can develop the clinical syndrome, the clinical toxidrome of methemoglobinemia. The blood in methemoglobinemia typically has a chocolate brown color to it. The picture that you see on the right side of the slide has two arterial blood samples. The arterial blood sample on the right is normal arterial blood, and you'll notice it has a bright red color to it. The arterial blood sample on the left is methemoglobin, and you'll notice it has a brown color to it. Because the blood is brown colored, the patients may look cyanotic, but not necessarily distressed. A young, healthy person with an elevated methemoglobin level may have a cyanotic or a grayish appearance to them, but because they are young and healthy, may not be experiencing any signs or symptoms from the methemoglobinemia. On the other side, a patient who has multiple chronic diseases such as COPD, coronary artery disease, or cerebral vascular disease, even a little bit of methemoglobin may cause them to become symptomatic. In patients with methemoglobinemia, standard pulse oximeters will typically read in the mid-80% range. The standard pulse oximeters are not accustomed to the brown blood, and therefore the default will be into the mid-80s. This next slide shows pharmaceuticals and chemicals that can cause methemoglobinemia. This is a partial list because there are more medications and more chemicals that can cause methemoglobinemia, but these are just some of the more common ones. Under the medications, you will notice there is benzocaine, lidocaine, and prilocaine. Local anesthetics are known to cause methemoglobinemia when given in excess. Another two pharmaceuticals that are well known to cause methemoglobinemia are dapsone and phenazopyridine. The chemicals on the right-hand side of this slide all are either nitrates or aniline derivatives of some sort. They are potent oxidizers, and they can cause methemoglobinemia. Signs and symptoms that we get from methemoglobinemia include normal pupil size, decreased blood pressure, increased heart rate and respiratory rate. Temperature is typically normal, and the mental status will depend on the severity of the methemoglobinemia. The mental status can be anywhere from lethargic or agitated all the way up to coma and seizures. This slide shows signs and symptoms based on a methemoglobin percentage in the blood. The methemoglobinemia toxidrome results in inadequate oxygen delivery to the tissues. So the more hemoglobin that has been converted to methemoglobin, the less hemoglobin is available to deliver oxygen to the tissues, and the less oxygen gets to the tissues. Therefore, the signs and symptoms worsen as the methemoglobin level increases. So early on, with a low methemoglobin level, you may have a gray or cyanotic color to the skin. After that, you get the chocolate brown color of the blood. But as the oxygen delivery to the body gets worse, you wind up with dyspnea, headaches, dizziness, the possibility for syncope. At very high levels, such as 50 to 70%, you can wind up with metabolic acidosis, arrhythmias, seizures, coma, and in levels of greater than 70%, typically result in the death of the patient. Treatment of methemoglobinemia. There is a specific antidote for methemoglobinemia, and that is methylene blue. Doses of 1 to 2 milligrams per kilogram of methylene blue typically reverse methemoglobinemia in the vast majority of patients with methemoglobinemia. Because methylene blue is a dye, giving intravenous methylene blue for methemoglobinemia will result in blue urine. If the patient hasn't responded to 1 to 2 milligrams per kilogram of methylene blue and the patient still has significant methemoglobinemia, usually that means that there has been inadequate methylene blue given, or the patient is still being exposed to whatever chemical or pharmaceutical it was that caused the methemoglobinemia. If methemoglobin levels are not available and the patient has empirically been treated for methemoglobinemia with methylene blue and they are not responding, the diagnosis of methemoglobinemia may not be correct. The Iowa Poison Control Center has produced a Toxidrome pocket card that summarizes all of the important points discussed in this presentation. You may either call or email the Iowa Poison Control Center to ask for this free pocket card to be sent to you or your organization. The card will also be available as an electronic download from our website at www.iowapoison.org. I would like to thank you for your participation in this presentation. If you have any questions about toxidromes or are dealing with a patient that has or may have a toxidrome, please call the Iowa Poison Control Center at 800-222-1222. And our nurses, pharmacists, and physicians will be happy to talk to you and help you 24 hours a day, 365 days a year. Thank you.